I'm just going to use this space if you don't mind.
Perfect. Oh.
No. Just as long as you keep videotaping our kitchen back there.
You're going to see your room.
Yeah. You said to press the play button. I don't want to not have a video later. You said to press the play button. It's recording. Yeah, I did.
Oh yeah, no, it's on. It's on. So everything you're saying is recording right now. Okay. Okay, so we will start with chapter 14. Now, chapter 14 goes over pretty much all different types of hematologic issues. Okay, such as blood coagulation, blood flow issues, when patients have an issue when we're talking about excess bleeding, okay? So when we talk about blood coagulation issues, this is the issue where a person does not have a normal blood clotting process, okay? Now when we talk about blood clotting process, normal blood clotting process, what do you know is involved in that process from just basic anatomy, physiology? Platelets, very good, so we know that platelets are extremely important in that process. What else do you know that's part of that clotting process? White blood, not so much white blood cells in clotting and coagulation. White blood cells are there for repair. But what about coagulation? What else along with our platelets? So we know platelets are definitely there. Clotting factors, very good. Clotting factors are extremely important, so don't forget that. And we'll go over that again in a little bit. And then also, if you remember that coagulation cascade, I don't know if you guys remember, but calcium is also extremely important, okay, when we talk about blood coagulation. Okay, so we'll go over some of these things. Now, when we talk about the term hemostasis, this is the arrest of bleeding or prevention of blood loss after blood vessel has been injured. So if we're talking about bleeding or a cut or injury to the vessel wall and blood starts to spurt out, okay, this is when we're talking about the stopping of that blood, so hemostasis. So we wanted patients obviously to have good hemostasis, but sometimes patients don't have good hemostasis, okay, because of certain issues. This will involve the vessel wall, circulating platelets, as you said, and definitely, as you said, the coagulation factors or coagulation proteins, which are extremely important with blood clotting. Now, the stages of hemostasis. So how does this whole blood clotting cascade start? Okay, so everyone knows, yes, platelets. Platelets rush to the site of the injury and they try to make that platelet plug and so forth and stop the blood. And then keep in mind that fibrin comes over, makes that fibrin mesh, okay, if you remember that, and seals the deal. So just keep in mind that that's part of it, but then we also have a lot of other things that are missing from that coagulation cascade. So we do have to break this down, okay? So primary hemostasis, this is the initial response to the vascular injury between platelets and the endothelium of the injured vessel. So what does this mean? This means, say for example, you're in the kitchen, cutting up some onions or whatever, making your dinner, slice your finger. Now when you slice your finger, what happens is you break the epithelium, but you also break the endothelium of the vessel. So when you break the endothelium of the vessel, now the vessel wall is exposed. It's almost like a little crack, okay? When that crack is there, what's going to happen, obviously blood will start to spill out. But what will now happen is that the first thing that happens, people tend to forget, is that the blood vessel itself will vasoconstrict, okay, before platelets even start to go to the area. So just like any type of normal response the body would do, just like if you were to touch something hot or someone scares you or whatever, you curl up or you pull back. So it's the same situation with the blood vessel. So as soon as the injury happens, it will go into a vasoconstriction. So that vasoconstriction will now cause the vessel to try to pretty much decrease the size of that crack, so to speak. Now, once we have vasoconstriction, the next thing that's going to happen is the platelets will rush to that area that still has a little opening and now form what is called the platelet plug. Okay. I want you to jot down, and I'll give you the full bleeding time in a second, but I want you to jot down that it takes 3 to 7 minutes to make a platelet plug. So it'll take 3 to 7 minutes for your body to form a platelet plug. Now, the next thing that's going to happen is once we have that platelet plug, the body will go into what is called secondary hemostasis. Okay, so what is secondary hemostasis? This means the formation of the fibrin clot by the way of the intrinsic and extrinsic pathways. So when we talk about extrinsic and intrinsic pathways, just to simplify this for right now, this is going to be the release of all our clotting factors, okay, during these two pathways. So the intrinsic and extrinsic is the release of all the clotting factors. And just to give you a heads up, why would we release clotting factors? The purpose of releasing clotting factors is to attract more platelets. Okay, so this is the whole reasoning to make this really thick platelet plug. And then the end result will be the fibrin. Okay, and I'll show you a chart in a second. Now, just to let you know, total bleeding time, which includes the formation of the platelet plug along with this whole secondary hemostasis, occurs between 3 to 10 minutes. And I think your laboratory sheet there says 3 to 9.5 minutes, okay? So let's just say 3 to 9.5 or 3 to 10 minutes. That is what we call total total bleeding time. I'm sorry, can you look under? I'm confusing myself.
9.5 or 10 minutes.
It's minutes. It's
Oh,
minutes,
minutes.
and I'm gonna tell you a story why I know it's minutes. Total bleeding time.
What did I say?
Okay, I'm sorry. I thought it was in there. I know that's not good for video. Oh, I know it's on the slide later on. Okay, it's okay. We have it on the slide later on. So total bleeding time, and we'll go over this again, so don't worry. Total bleeding time is going to be 3 to 9.5 minutes. Okay. Now, to tell you a story, and this is now going to be also a critical thinking question I have for you guys. Had a student in anatomy. One term I taught anatomy lab. And you know how if you took anatomy here, if you guys remember doing the dissection of the spinal cord and you had to cut the vertebrae? You guys remember doing that dissection? Okay. Well, remember those scalpels sometimes are a little flimsy, okay? And so after the incident that happened in my class, I actually ordered bone cutters because we had a really bad problem. So, student in the 7 a.m. class sliced his finger. And we had a bleeder, okay? And he was bleeding past the bleeding time, okay? Past the bleeding, the normal bleeding time of 9.5. And so he got nervous, and one of the nursing instructors came in, and everyone was really nervous. And he knew something was wrong because he was bleeding a little too long. So long story short, he was okay. They went to urgent care, got him some stitches, and he was good to go. Okay. Now, let me ask you, if someone goes outside of their bleeding time, what could be some things that you think could be the issue why they're bleeding a little longer than they should? Okay, so possibly thrombocytopenia, very good. So possibly low platelet count, okay, from whatever reason. Okay, so we don't want to diagnose the person at that moment and say, well, you have this going on or whatever type of disease process. But definitely that, okay, that's probably one of the causes. What else could be a reason?
Medication.
Okay, possibly medication. Maybe that person was on blood thinners. Okay, that could cause them to have this sort of prolonged bleeding. Very good.
Does the severity of the cut matter?
The severity of the cut could matter. And his cut was pretty deep.
So maybe it was arterial instead of...
Okay, now if it was arterial, what would happen? It will spurt out. Okay, so keep in mind, and I'll go over this again, I think, with chapter 15, the difference between arterial blood and venous blood is very slow, okay, in vascular system, whereas arterial blood has a higher velocity. So if you ever watch those gory movies and they cut someone's artery and it's just spurting out, okay, that's exactly what happens with the artery. So if someone severs an artery, you'll know.
Difference in color too.
Yes, and it's bright red. It's bright red. You'll know, and you'll have to try to cover yourself. Okay. Now, what else could be the problem? There's one more thing. If this person, yes.
Absence of clotting
Yeah.
Absence of clotting factors. Okay, very good. So absence of clotting factors. So we don't want to say, oh, maybe this person has a hemophilia or von Willebrand's or whatever. We don't want to go there yet, but it could be a possibility. And then one more thing that you're missing that I went over. That could be part of it, which is part of the whole clotting factor. Possibly low calcium. Very good. And what else? What is the first thing the vessel does? Vasoconstrict. So it could be an issue with the vessel vascularity, where I should say vascularity, excuse me, but the muscle constriction of the vessel, where the vessel is not recoiling as it should. Okay, so it could be severe muscle damage or to the vessel or vessel damage. Okay, so very good. So keep in mind that when a person has an abnormal bleeding time, that does not give you the diagnosis at that moment. That's just saying that, okay, maybe it could be platelets, it could be clotting factors, it could be a whole bunch of things, but that will just give you the first part of your assessment. Yes?
I just had a story.
Oh, go ahead, tell your story.
Okay. Well, okay, so my Asian parents always use like those big butcher knives
Yes.
to cut everything they had. And,
Your parents are Asian? Your parents are Asian?
well, hello!
Right.
And they're scared of knives, so they always keep it dull. And that actually makes it worse. When it's dull, it's more dangerous, right? And so this one time, my mom told me to start cutting her potatoes. And so she was at work, she told me, oh, Jenny, can you help me cut our vegetables for the curry? I said, okay, okay. So I take out her butcher knife, and I live in Riverside, so I use the real legit knives that are sharp, and they're from Rachel Ray, you know. I go back home, I use the butcher knife, and I was cutting the potato, and you know how it's so starchy?
Yes.
It completely, because it's round too, and so it just big butcher knife just chopped part of my finger off. But it did take 10 minutes for it. It took a long time.
You're bleeding. Okay, you were past the bleeding time. Okay.
It was past just a little bit, though, but on average it is right, you know.
Right.
But because the cut was probably so severe, because it cut off my nail too,
Oh.
the finger bone. And so from that day on, every time I cut potatoes, I get a cut. I hate potatoes.
You cut yourself every
now,
time.
it's like
Wait, I'm so confused. You cut yourself every time you cut potatoes?
yes,
Don't cut any more potatoes.
I'm not. I stopped using a knife and I started using a mandolin. And I cut myself with a mandolin and a potato. Because I thought, okay, I'm not going to cut any more potatoes with a knife. I'll use a mandolin instead. And then it got worse.
Yeah, you have to be careful. And like you said, you're right with the dull knives. Any knife, even if it's sharp too, it doesn't matter. It's also like with the forcing. If it breaks, no matter if it's dull or sharp, if it breaks the epithelium, that's it. You're cut. I'm afraid of big knives too. I actually use little knives. Yeah, so I use So I have the same scare. But so what happened to your finger? Did you get stitches?
No, I just let it do its own thing. Let the platelets do its own thing. And
So you cut it by the nail?
Okay, so I cut it, but I didn't cut it all the way so the skin didn't fall on the board. It just kind of flip around. Do you know what I mean?
And so your
It was
finger.
attached still.
Oh, your finger was still attached. Oh, okay. I'm thinking it wasn't attached.
No, it was still attached, but it was hanging by a piece of
okay.
skin that could go like this.
Okay, I thought it was still attached.
All right, so both sides.
You know what happened was it started to for the
So chapter 14.
Okay.
but then it started growing a black thing around it. Probably the dried blood.
Yeah. So your healing process took place. Now keep in mind, since we started there, okay, talking about your story. Now what happens with the coagulation cascade, and the end result we know is the platelet plug and the fibrin mesh, and it stops there. Now, what else is going on when you're going through the coagulation cascade? Someone said it earlier.
Your white blood cells.
Okay, white blood cells. Okay, so the white blood cells, keep in mind, are there so your immune system is definitely kicked in, especially at a time of injury. Okay, so, and that's there to reduce susceptibility of infection or whatever else that may be going on from the butcher knife or whatever, you know, could have cut the finger. So just keep that in mind, that those two things go hand in hand. And also when we have those types of white blood cells and inflammatory cells, that what's left over sometimes, that when the healing process takes place in what we call the scab, okay, and pus, is actually leftover white blood cells from the immune system. Okay, so that's just leftover white blood cells and inflammatory mediators and whatever that was left over from that immune process. So just keep that in mind, that those two things go hand in hand, even though we're just focusing on coagulation right now. But even what you're talking about, the black thing and that healing process that's taking place, a lot of that was part of your immune system too. Okay? All right, so very good story. Thank you. All right. Now, platelets. Keep in mind that platelets, as I told you, they are released, when there is a situation of injury to the vessel. Now, what will happen is that platelets, and I'm sure you've heard the term of sticky platelets, sticky. Okay, so they are sticky, if you want to say that, and what they do is they actually stick to the endothelial wall. So right when you have that opening, those platelets are just kind of go right to that area, get stuck in like a little piece of sticky glue or something, and just get stuck right there. Now, once they get stuck to the wall, they start to go through a process of where they do get activated in something called degranulation. Okay, so what does that mean? That means that as they go through degranulation, they will start to release different types of granulars, okay, that are part of the platelets. Now, these granulars will then release what are called clotting factors. Okay, so those granulars do release or start the process of our clotting factors. So this is what you should understand. Okay, so I'll backtrack. I'll say it again. Sticky platelets stick to the vessel wall. Once they get stuck to that vessel wall, they will start to go through a process of degranulation where they will break down. And as they break down, these granulars that are released will now release clotting factors. Now, what's the point of releasing clotting factors? What you should know is that these clotting factors will send a signal through the bloodstream and now attract more platelets to the site. Okay, so much like the chemical mediators in the immune system and how they just attract more white blood cells to come to the area, same situation here. Okay, these granulars will be released, chemical mediators will flow through the bloodstream and say, platelets, hey, come over to the area to attract more platelets to make that platelet plug even thicker. Okay, so is everybody with me with that? Okay. Now, this picture here I'm not so concerned about. It's just showing you the receptors on the platelets that have all the different factors that are released and so forth. So we don't have to worry about knowing each one of those. And I'm not concerned about this either. Now, two things I do want to go over. Okay. I wish I had it. Now, most clotting factors are synthesized by the liver, which I think some of you guys know this already from anatomy. Okay, we know that the liver does secrete some plasma proteins and also clotting factors. Please make sure you know this. This is important to know because clinically, if you have a patient that has a liver disease or some sort of issue with their liver, is it a possibility that they can have a coagulation issue? Yes. Okay, because they may not be developing enough coagulation factors for clotting. Okay, so that should always be a question if someone has vascular issues, okay, if they're having issues with bleeding and so forth. You want to see, have they had a history of liver disease or any problems with their liver, because that can also be part of it. Okay. Now, factors 2, 7, 9, and 10, protein C and S, are dependent on vitamin K for synthesis, which is extremely important to know, and I think you talked about this. Vitamin K is extremely important for making these clotting factors, okay? So which means that if a person's vitamin K deficient, yes, they will have an issue with blood coagulation, okay? And sometimes infants are born with this, and sometimes people can acquire this as an adult as well, vitamin K deficiency. Okay. Antithrombin 3 and protein C promote what is called anticoagulation, okay? Now, why would we want to have anticoagulation? Why would we want to stop the blood clotting? Very good, because we don't want to have overclotting. Okay, so keep in mind that once you have a cut, your body goes through the normal coagulation process. You have your blood clot, it seals the deal, you're good to go. We do not need to continue the whole coagulation cascade and make a very thick clot, because now that clot is going to turn into an abnormal blood clot, okay, or what is called a thrombosis, okay, and we don't want that. So just keep in mind that anticoagulation is very important. It is a compensatory mechanism where your body will recognize, okay, well, we have too much, we want to try to normalize the situation, stop the clotting right when it needs to stop. Now, two other things I need you to jot down, and I wish I had a board. I can, and I always goof it up. So let me see.
Dude, it's raining though.
Is it raining?
Oh, you probably
No,
need
you
to
have
go
to
to
click
the
it.
You need to go to the notepad thing. Switch it over to notepad. That clear like.
I don't know why it's not. Oh, over here.
No, click the other, the top one.
This is gonna be a terrible video.
Top.
You know, you know what? I'll just leave it alone right now because I'm gonna. Okay. Just jot this down. There's two drugs that we know that we give patients when they have clotting issues, and this is when I'm talking about abnormal blood clotting. Okay, so I don't mean to confuse you, but we're just gonna switch and talk about abnormal blood clotting. So when patients have maybe a DVT or some sort of thrombosis or something, so we're going to talk about the two medications, Coumadin and heparin. Okay. So. Okay. So warfarin, which is the title, okay, of Coumadin. Okay. Because then they have different types of it. So warfarin, W-A-R-F-A-R-I-N. Warfarin, commonly known, Coumadin is one of the commonly known types of warfarin that is used. Okay, Coumadin. I want you to know that this medication interferes with the vitamin K dependent factors. So this medication interferes with the vitamin K dependent factors. So which means this Coumadin will interfere with this process and stop it, therefore causing these patients to have coagulation issues. Okay, I shouldn't say issues, but causing them to have a decrease in coagulation. Now, heparin, the medication heparin works by enhancing antithrombin 3. Okay, so that's easy enough. Heparin works by enhancing the activation of antithrombin 3. So therefore, it will cause anticoagulation.
Did you say it will cause coagulation?
It will cause
Okay.
anticoagulation. Anticoagulation. Okay. Are we okay with that information?
Activation of what?
Antithrombin.
Yeah, so, yeah, patients that have abnormal blood clotting. So those two medications are used for patients that have abnormal blood clotting. Say, for example, patients that have a deep vein thrombosis, which we're going to go over in chapter 15, and then I'll tell you my story, okay, with that. Now, those two medications, please make sure you know those medications. I will possibly test you on those, okay? So make sure you know what they are and how they interfere with this coagulation cascade.
Do we know warfarin or
Yeah, what about Coumadin?
Know both names. Know both names. And when you get to pharmacology, they'll go over all the other subtypes of warfarin.
Real quick, just to get some clarity here. You said to know how they interfere with the cascade, but you only went over heparin's interference with the cascade. Not
Oh.
Coumadins or warfarins.
Well, Coumadin and warfarins, what they do is they interfere with the vitamin K synthesis coagulation factors. Yeah, so that's their interference with the cascade. They interfere with the vitamin K factors.
And then heparin is
Heparin just increases antithrombin 3.
Got it.
So just make sure you know those two. Okay. And then protein S assists protein C with binding phospholipase, which stimulates now plasminogen, which will then activate fibrinolysis. Okay. This will make more sense. I'm going to show you a diagram in a second why we go through the process of fibrinolysis. Okay. Now, this chart here, don't get nervous. Okay. You don't have to memorize this, but when you look at the coagulation cascade flow chart that I'm going to show you in a second, if you need to use this as a reference just to go back and see, okay, well, what factor does what, just to get a better understanding, you can use this as a reference, but I'm not going to test you on this entire chart. Okay, so don't have to worry about that. Now, intrinsic pathway and extrinsic pathway, what happens here is they're explaining to you what are the difference between the two. Intrinsic pathway is when there is an issue with the endothelium or the inside of the vessel. So the inside of the vessel, when that gets damaged, that is now going to secrete certain factors. When we talk about extrinsic pathway, this is when the outside of the vessel, okay, gets damaged and then it releases certain factors. Okay, so there's two different processes that happens, okay, from that. Is everybody with me? Now, this is the coagulation cascade. Now, let me just walk you through this to make it life easier, okay? So, they show you here the intrinsic pathway and then the extrinsic pathway. Then you have the common pathway, which most of you guys probably know from basic anatomy, okay? Where it went over the platelets, and then we have prothrombin, the thrombin, fibrinogen, the fibrin. That should sound familiar to you, correct? Okay. Now, let's start up here. What I want you to know, to make your life easier, please make sure you know the factors that are involved with each pathway. So make sure you know which factors are part of the intrinsic pathway and which factors are part of the extrinsic pathway. And make sure you know what factors are also involved in the common pathway. Not only will you be tested that way, but what will also happen is that we're going to get to, I think, 2 or 3 more laboratory testing. And we have laboratory tests that just test the intrinsic and ones that just test the extrinsic, okay? And so when you get a test result from that, then you have to figure out, okay, well, this could be factor, 5, 10, or whatever. Okay, so this is how you have to work it. Now, make sure you also pay attention to calcium. Calcium is here in intrinsic, here it is again in extrinsic, and here it is again in common pathway. Calcium is extremely, extremely, extremely important in blood clotting process. A lot of people tend to forget that, but it's extremely important. Now, just to pick your brain and make you go back to your endocrine system, what 2 hormones regulate calcium? Parathyroid hormone, and then what is the other one that can also push it down? Calcitonin, okay? So keep in mind that calcitonin decreases blood calcium levels. And remember, parathyroid hormone will increase calcium levels in the blood, okay? So at any event that your body recognizes that it does not have enough blood calcium, which is needed for blood clotting, your parathyroid hormone should be kicking in to now help secrete more of this calcium levels. Okay, is everybody with me? You need to repeat that? Oh, okay. Okay, now, let's go back down here. So this is the common pathway. So you have all your factors here, factor 10, okay, and we have our platelets coming in. There's calcium. Prothrombin, we know, converts to thrombin, which is important in the conversion of fibrinogen to fibrin. Now, what is the purpose of having fibrin? You should know this.
What does the actual clotting? It provides the consistency of clot.
Okay, very good. Now, fibrin, what happens, it makes sort of like that net
Forming.
that sits over the platelets. So it kind of seals the deal, okay, that fibrin. So we have our platelet plug, very thick, and then the fibrin will come over and just make what is called a fibrin mesh, really. And that fibrin will sit on top of the platelets, okay, and just really seal up that whole thing. Now, when we have fibrin, as you can see here, it makes this nice clot, as they're showing you there. Once we have that clot, as you can see, it's going through a stage of what is called fibrinolysis. So to break that term down, fibrinolysis means to split fibrin, to break that fibrin down. Why would we want to break down the fibrin? To avoid clotting. And fibrinolysis is going to happen after what?
It's healed.
Very good, after it's healed. Keep in mind, as I told you before, immune cells are there and they're helping the whole thing. And so once that epithelial tissue starts to regenerate and it's nice and it closes up, then we don't need that clot anymore. It doesn't need to stay there. Okay, and if it stays there, that's a whole other issue. But we don't need it to stay there, and so when it's done healing, then we can go through the stage of fibrinolysis, break down that clot, okay, and now have a nice smooth epithelium back to where it was. Okay, so almost like Jenny's finger, hopefully it should be nice and smooth, okay, by now. So, now, this is just going over the whole process of fibrinolysis and which factors are involved, okay, so you can read that at your leisure. So this is the pathway here. So plasminogen activators convert plasminogen to plasmin, which now begins that fibrinolysis stage, and it breaks down the fibrin into little tiny pieces.
See when you know the process of that.
Yes, please. Yes, know this diagram. Now the next thing we have to go over is, before we get into all the different types of coagulation diseases, let's just review how you would do any kind of evaluation or management of patients that have coagulation issues, okay? So the first thing is they go over here is with evaluation. This is included with definitely patient history and physical. You want to determine what's going on so you'll know obviously how to manage the patient. And this type of evaluation is extremely important, obviously, if patients have a history of bleeding disorders, definitely before they have any type of surgery, okay? You definitely want to know if a person has a coagulation issue before surgery, before you go cutting and then they're bleeding all over the place. Also, too, this is used as a management if patients are on things like a Coumadin or heparin. You want to definitely evaluate and make sure that they're not having now going into a further bleeding disorder after being on that type of medication that's going to thin the blood. So this type of evaluation is extremely important. Okay. Now this chart here is very nice. I would say to please highlight this chart because what it goes over with you is from a patient's history, okay, and what possible diseases, coagulation disorders could be here. Okay. So bleeding in both males and females, von Willebrand. Bleeding in males most of the times, well I shouldn't say most of the times, but males are more along the lines of hemophilia, okay, A or B. Newly acquired bruising. Sometimes patients can just have bruising, okay, on the skin, and I'm going to show you some pictures in a little bit. That type of bruising could be from maybe